Consensus recommendations for the categorization and management of low back pain. We're going to review 3 related studies that are a well-designed sequence of process that lead to recommendations for the management of low back pain in the VA system. The first study's goal was to review the literature regarding the diagnostic categories of low back pain and develop a rationale for each that can be mapped to a given patient presentation. Additionally, using this information in the second study, a diagnostic checklist approach for the clinician was developed. The third study attempts to determine through a consensus approach what would be a usable management menu in the VA system for each category of patient designated in the first 2 studies. So who made up the team? The investigative team consisted of members with expertise in chiropractic, clinical research, and Delphi Process methodology. All 113 VA chiropractic providers, 113 in total, were invited to rate the clinical decision-making materials and provide critical feedback. So in essence, merging together the literature on diagnostic categories with a pragmatic approach to care delivery. So the Delphi process is a structured communication approach where a team of experts are involved in the evaluation of evidence. The experts answer questionnaires in 2 or more rounds. After each round, a facilitator provides a summary of the experts' input from the previous round, as well as the reasons why they provided their judgments. This is done anonymously. If consensus is not reached, the process continues to gradually work toward synthesis and building consensus. Let's start with the first in this 3-part series of studies. It was published in 2019 in the Journal of Manipulative and Physiological Therapeutics and is entitled Current Evidence for Diagnosis of Common Conditions Causing Low Back Pain, Systematic Review and Standardized Terminology Recommendations. Now, a reminder of what a systematic review is and how it differs from other studies. It uses strict methods to locate, appraise, and synthesize all research on a topic. They focus on high-quality studies like RCTs and sometimes prospective studies. They're designed to answer specific clinical questions and are therefore a potentially good source of evidence transference that is applicable to practice. Multiple reviewers are usually involved. Articles are evaluated using appraisal instruments which rate the literature using guides and scales related to scientific rigor. Dissimilarities between the findings of studies are investigated, and any disagreements are resolved. Let's start with a common assumption made by chiropractors and medical doctors when diagnosing low back pain with radiation. The assumption by many is that it is nerve pressure due to a disc herniation or facet impingement of a nerve. Yet disc herniations account for only about 5% of low back pain cases, and only 1% of low back pain cases have neurologic deficits. So what then could be another possibility? Well, categories help. The researchers in this categorization process were very clear in differentiating 3 major types of pain: nociceptive pain, neuropathic pain, and sensitization. Why? Because the type of pain processing, structures, and clinical findings are different for each, and given the source is different, management approaches are likely to be different. The first differentiation can be thought of as abnormal function due to pathology. This is neuropathic pain, versus normal function due to conveyance of pain from non-neural structures. This is nociceptive pain. It follows then that there is likely a mechanism of stretch or compression, and there are objective findings possible with a neuropathy, including for spinal nerves deficits for a dermatome, myotome, and deep tendon reflex. And it also follows that for nociceptive pain, given neural tissue is not pathologically impacted, that there would be no objective findings. And note that the nociceptive function of 2 nerves is involved, not nerve roots. The sinovertebral nerve, also called the recurrent nerve of Luschka or recurrent meningeal nerve, and the medial branch of the posterior primary rami. Nociceptive pain is likely due to irritation of the following structures: disc, facet, SI joint, or myofascial tissue, and therefore activation of the related pain-sensitive nerves. By definition, it's pain from nociceptor activation in response to actual or threatened damage to non-neural tissue. It can be local or refer. Here we see a graphical representation of the deep spinal structures that include the disc and facets. Note the dorsal root ganglia are where sensory nerve cell bodies are located. The sinovertebral nerve innervates the anterior dura, posterior longitudinal ligament, and posterior disc, and the vertebral body. The gray rami communicans, part of the sympathetic nervous system, innervates the more lateral aspects of the disc. And here we can see on this axial rendition of deep spinal innervation that the medial branch of the posterior primary rami innervates the facet joints with overlapping of a few segments above and below. Note too that the sinovertebral nerve anastomoses, and that causes a perception of central pain rather than lateralized pain in most cases of stimulation, whereas the medial branch of the posterior primary rami is sided, meaning it has a left and right component. For neuropathic pain, the research group divided categories into radicular, radiculopathy, and neurogenic claudication, with the common definition that pain is caused by a lesion or disease of the somatosensory nervous system. They then differentiated from peripheral neuropathic pain, which includes the Piriformis syndrome or thoracolumbar syndrome, and is defined as pain from inflammation, compression, or entrapment of peripheral nerves in the lumbar region. Sensitization may be central or peripheral and is described as an increased responsiveness of nociceptive neurons to their normal input and or recruitment of a response to normally subthreshold inputs. Now let's move to the second publication, again published in JMPT in 2019, entitled Development of an Evidence-Based Practical Diagnostic Checklist and Corresponding Clinical Exam for Low Back Pain. As stated in the title, the goal was to develop a history and exam checklist for each category. Refer to the article for the more exam form format presented in the study. For nociceptive pain, the common features are there is a clear proportionate mechanical or anatomical nature to symptoms. Pain is in proportion to trauma or pathology. Pain is in an area of injury or dysfunction with or without referral. The pain resolves consistent with expected tissue healing time. It's usually intermittent and sharp with movement and or mechanical provocation, and pain is associated with other symptoms of inflammation, which may include swelling or redness. For neuropathic pain, the common features are there is a history of a lesion or disease of the nervous system, pain is neuroanatomically distributed, sensory dysfunction is neuroanatomically distributed, and the quality is described as burning, shooting, or pricking. And for sensitization, low back pain is disproportionate to the nature or extent of the injury or pathology. There is a neuroanatomically illogical pattern, and there is hypersensitivity of senses unrelated to the musculoskeletal system, including generalized sensitivity remote from the low back pain area, hypersensitivity to light, sound, stress, food, or chemical stimuli. Before we proceed, the exam clusters listed are defined as either being expert opinion-based or literature-based. Those that are from the literature are accompanied by their calculated likelihood ratios. For those unfamiliar or in need of a refresher, here's the bottom line. Positive likelihood ratios relate to a positive response to a test. The likelihood ratio is based on sensitivity and specificity and has a corresponding number that relates to a small, moderate, or large probability that an individual does in fact have the disorder. In other words, leads in the direction of ruling in a disorder. The scale is easy to recall. 10 equals a 45% increase in the probability of the disorder tested, and a likelihood ratio of 5 equals a 30% increase, and a likelihood ratio of 2 equals a 15% increased probability. Most of the time, clusters of tests are needed to create a significant level of probability. Although not discussed in these studies, a negative likelihood ratio relates to the probability of ruling out a disorder when a test is negative, and has a corresponding scale of 0.1 for a large probability shift of 45%, 0.2 for a moderate effect of 30%, and 0.5 for a small probability shift against the disorder by 15%. Let's start with the facet joint. The test cluster includes 3 or more history or test findings. They include age over the age of 50, the onset location of pain is paraspinal, pain is relieved with walking or sitting, and there is a positive extension rotation test. For the SI joint, the test cluster includes Gainsland's on the right or left, thigh thrust test, distraction, sacral thrust, or Patrick's test. If there are 3 or more positive SI joint tests with centralization, the likelihood ratio is 3.93, and for 3 or more positive SI joint tests without centralization, the positive likelihood ratio is 7. Centralization refers to the phenomenon of pain centralizing to the low back. For discogenic pain, diagnostic evidence includes centralization with repeated motion in any one or more of the following: standing with flexion, extension, or right or left lateral shifting, and in a recumbent position, prone extension or supine flexion. For neuropathic pain, the test cluster includes pain that is described as either burning, cold, or electric shock sensation, pain associated with tingling, pins and needles, numbness, or itching. The pain location is associated with hypoesthesia to touch or pinprick on exam, and the pain is increased by brushing the area associated with the pain. The test cluster is 4 or more positives. For sensitization, low back pain is disproportionate to the nature or extent of the injury or pathology, and hypersensitivity of senses unrelated to the musculoskeletal system, as mentioned earlier. With neurogenic claudication, the test cluster includes symptoms triggered with standing, relieved by sitting, symptoms primarily located above the knees, and a positive shopping cart test. And we see likelihood ratios if 2, 3, or 4 criteria are met. For radicular pain, it's described as lancinating, traveling along a narrow region, traveling beyond the spine, and is described as episodic, recurrent, or paroxysmal, which means sudden and without warning. With radiculopathy, there are objective findings of nerve root conduction loss in the distribution of a spinal nerve found with decreases in deep tendon reflexes, motor strength, or dermatomal hypoesthesia or anesthesia. For the piriformis, radiating pain into an ipsilateral leg, tenderness of the greater sciatic notch, buttock pain, a positive straight leg raise test, and increased pain with prolonged sitting. And for the thoracolumbar syndrome, also called Main syndrome, there's pain in the cluneal nerve distribution, either at the iliac crest, groin, or greater trochanter. A trigger point over the iliac crest approximately 7 centimeters from the midline, sensitivity to iliac crest skin rolling, and tenderness of 1 or more thoracolumbar spinous processes or facet joints. And they also included criteria for peripheral artery disease leading to vascular claudication, evaluated with the ankle brachial index. And now to our final of the 3 studies, which focuses on application. It too was published in JMPT in 2019, entitled Development of a Clinical Decision Aid for Chiropractic Management of Common Conditions Causing Low Back Pain in Veterans, Results of a Consensus Process. In addition to the suggested management approaches, they list in this study the evidence for each of the suggested approaches. We'll now cover the menu of approaches recommended based on the patient's category of pain. For nociceptive pain management, recommendations for facet syndrome, discogenic pain, and myofascial pain include education about the condition, spinal manipulation, heat, massage or low-level laser, motor control exercise, general self-care and self-management advice, and also to consider recommending mindfulness-based stress reduction, and for myofascial specifically, myofascial-oriented therapies such as ischemic compression as indicated and as tolerated. For radicular pain management, for both radicular and radiculopathy and neurogenic claudication, education about the condition and neurodynamics. For radicular and radiculopathy, spinal manipulation and directional preference exercise, and for neurogenic claudication, lumbar mobilization exercise, self-management via cognitive behavioral approach, and home exercises when tolerated. For central sensitization management, recommendations included education about the condition, spinal manipulation, heat, massage, and low-level laser, motor control exercise, general self-care and self-management advice, spinal stabilization exercises, and self-management advice such as nutritional and general activity advice to improve fitness and strength. Also, education to prevent or reduce fear, passive coping, and catastrophizing, and to promote self-efficacy. refer or co-manage with a mental health provider for evidence-based treatments, such as cognitive behavioral therapy and acceptance and commitment therapy when appropriate, and mindfulness-based stress reduction. Although it might be easy to dismiss this study as too specific for the subpopulation of VA patients, it serves a much larger role. Given the VA has now an established diagnostic categorization and associated management recommendations, it is now possible to do more meaningful research. In the past, one could use inclusion-exclusion criteria to further narrow down the study population, but without an agreed-upon categorization scheme, it is difficult to know if results would be different with different patient groups. Now, either through different separate studies or by subgroup analysis, it's possible to see what works best for which group. In other words, of the suggested approaches, which combinations work best with which patient profiles. This goes far beyond the VA. It illustrates a needed process that should be implemented in the clinical population at large.